The Centre presents a new podcast, CBmE and You, a podcast devoted to promoting awareness and debate around controversial ethical issues in biomedicine.
Hello and welcome back to CBmE and You, a podcast by the Center for Biomedical Ethics. Today's topic, precision medicine. What is it? How can it be used? And what are the ethical implications of it? Joining us today is Dr. Saumya Jamuar, Director of the SingHealth Duke-NUS Institute for Precision Medicine, or PRISM. Welcome.
Thanks, James and Sinead, for this warm welcome and for inviting me to talk. I'm very happy to be here.
Thank you so much. We're so excited to get into the details today, but we have some more fun questions to get to know you a little bit better. Coffee or copy?
Copy.
Do you have a specific copy order?
No, just the regular.
Just the regular.
Nice.
Because so one thing I don't like about Starbucks, they have too many options.
It's a bit scary. Like you go into a coffee shop, you almost feel a bit too basic if you just say, I want a coffee.
Yeah.
I'm judging you for that a little.
Sinead is our local coffee snob.
I'm Australian. What do you expect?
Yeah.
Yeah.
But yeah, no, I just prefer kopi, and they'll be like, kopio, kopi sutai, kopi. Okay.
Are they like, whoa, we never get that?
The judgmental. Okay then.
Yeah, that'll be 180. Okay.
Next question. What country would you like to travel to the most?
So actually, I mean, I don't know whether people know, but I grew up in India, and then I moved to Singapore. And so the country that, everyone wants to visit is, in a way, India, because the way it's, is the cultural aspect, the natural beauty and all that. And having lived in India, I never managed to encounter that. So India would be one country that I'd like to go back to and as a tourist.
Yeah. Where in India did you grow up?
Delhi.
Okay. City centre.
City centre, yeah.
Big
Nice.
city.
So my dad was an academic. So within city centre, I was within the university compound. And so very different from Delhi itself. Very serene compared to the hustle and bustle just outside the university campus. Have you been to Delhi? Okay. It's a madhouse. It's a madhouse.
I would need some recommendations of where to go before going.
I know as much as you do because I haven't... I won't say how... It's been 3 decades since I left Delhi. So
Okay.
It's been a long time. It's changed, but...
And has Singapore been your home since?
Yeah. So most of the time, except for 2.5 years when I was in Boston doing my genetics training.
Oh, wow. Okay, cool. Now, my favourite question. What song would you sing at karaoke?
So it depends on what my daughters are playing. But I think for me, it'll be U2 Without You.
U2, as in the band U2?
Yeah.
Is that top charts at the moment?
It's not. But that's the song, yeah.
Okay.
You're allowed to like old songs.
Well, my only interaction with U2 was when Apple in 2010 downloaded all their songs onto everyone's phone without their consent. And so I was really angry about it because I was like, how dare you? This is my phone.
Yep. So maybe that's the reason why, because I have an old iPhone and it keeps playing without you.
Oh my God, you still have that.
Yeah.
So is this really your favorite song to sing, or it's...
An adapted preference.
Yeah, they've made it your favorite song.
No, it was. I mean, so I used to listen to U2 when I was in university before 2010. And then when Apple did this, it kind of... And I love Apple, so...
Oh, so it's just a coming together of your favorite things.
Exactly.
Wonderful. Thank you.
And then I was too lazy to delete it. So, so it's been on a loop since then.
Oh, wow. Good marketing strategy.
They gotcha.
Exactly. They got me a hello. Do you know that movie?
No.
Do you know that movie?
I know it's from a movie.
Anybody knows that movie? Jerry Maguire?
Oh,
Tom Cruise?
I know Tom Cruise.
Okay.
I'm so sorry.
I know about Jerry Maguire. I never saw it.
Okay.
Show me the money.
Yeah, that's
think
a
I've heard
famous
this.
line.
Okay.
That's from that movie Jerry Maguire.
Okay.
Because he's an agent for
Okay.
this football player.
Yeah.
And then they're talking about the deal and he's like, show me the money. And,
Oh, I thought that was a Rihanna song.
No.
Okay.
It could also be a Rihanna song.
But then there's a scene where he's trying to ask the female out, and he just goes on to this rant. She's like, "You had me at hello."
Oh, okay. Thank you for that.
Sorry, I'm just dating myself. Okay.
It's okay. You dated me earlier when, you knew more of the top Spotify songs than I did, so we're even.
Okay.
Yeah, and we all have like one really old movie that we can quote, so.
Mine's like Shrek.
If you think Shrek is a really old movie.
It is. It came out when I was a kid.
So, the one movie that's really number one, Sound of Music.
Oh, that's fair. Yeah, I respect that.
Thank you.
Classic.
Phew. I feel that we've connected.
Okay, now that we've defined what an old movie is, it's time to move on to the real questions. To define precision medicine. So, what is precision medicine, and how is it different from quote-unquote normal medicine? I mean, isn't normal medicine something that aims to be precise in the first place?
Yeah, so that's a great question. And so, again, I'm a sort of a history buff. So the word precision medicine was actually coined a while back, but the person who made it famous was Obama. In 2016, he gave a State of the Union speech, and he said precision medicine. And that's for the first time. If you look at the Google search for the word precision medicine, it went up like 100 times. Before that, precision medicine used to be called personalized medicine, which is basically tailoring medications or treatment based on what the individual needed, right? Unfortunately, medicine as we practice it today, it's a reactive form of medicine where the patient presents to us with a symptom, with a disease. We diagnose that disease and treat them based on what has been shown in a randomized controlled trial of X number of people, shown to benefit 70% of people, cause harm in 30% of people. And we say, look, this is a medication which works for you. Take it, come back in 2 weeks if you have side effects, come back in 3 months if you are feeling better. Right? And then we review them. So that's the current state of medicine. Precision medicine turns that around and says, look, if I can identify who is at risk of developing these side effects, the 30%, then I don't give the medication to them, right? So I avoid harm, right? If I can identify the 70% who benefit from this medication, I can ensure that I'm maximizing the use of this medication for the right group of people so they get the benefit and not the ones who won't benefit from it. So precision medicine is about identifying those individuals using different markers, whether it's genomics, whether it's environmental, whether it's whether there's family history, other omics, and saying which treatment option, and medication is just one arm of it, but which treatment option will work best for you as an individual rather than you as a group.
So in my head, I'm thinking, okay, so some antibiotics don't work on some people. And at the very basic level, and please correct me, you are trying to identify in advance whether or not this antibiotic will work on this person, who it won't work on, to make sure that it works the best. But is it for things other than antibiotics, like more harsh drugs or even just more basic drugs as well?
So antibiotics is a great example because what you're trying to do is based on a person's profile. You're trying to guess what's the organism that's causing that infection and then treating them with that correct antibiotics, right? So if I digress a bit, in pediatrics, when you're younger than 2, there's a higher risk for getting infection from what we call Streptococcus pneumoniae, and that's treated by ampicillin. Whereas if you're older than 2, then you get infection through Mycoplasma pneumoniae, which is treated by erythromycin.
Okay.
Right? And so depending on the age group, you're kind of saying, oh, you're younger than 2, you're likely to have streptococcus, I'm going to give you ampicillin, versus you're older than 2, likely mycoplasma, I'm going to give you erythromycin. So that's fairly common, fairly innocuous in some ways, because if you give them an antibiotic and they don't respond, then you change the antibiotic, right? Or sometimes just viral and they don't need antibiotics, right? But when we talk about precision medicine, we're talking, as you rightly said, some of the harsher things, including chemotherapeutic drugs. And this is when you want to treat the patient and give them the best chance to fight their cancer. and if you can identify what is the correct medication to give them, right? So one of the examples is this thing called 6-MP or 6-mercaptopurine, and there are some individuals who don't metabolize that well. You need them to metabolize or break it down into its active product before it becomes before it does the job it's supposed to do, and if it doesn't, it causes side effect. So in individuals, if you can identify who can and who cannot, you may want to avoid the medication because you don't want to give them the side effect.
So does this mean that you need like a big database of all the factors about a person, genomic, other various traits about the person before this health problem arises? Like, does a patient need to have a lot of tests under them in order for precision medicine to work?
So in precision medicine, data is the key. So the more you know, the better you can, the more precise you can be. But one of the things about medicine is it's as much a science as an art. So we tend to make decisions based on incomplete data points, best guess in that sense. And so we don't need to do n number of tests to identify what would be the most appropriate. What we do is what's the most basic but also cost-effective option in terms of doing that. So as part of practicing and implementing these into medicine, we need to look at all the aspects, not just the whether we have the biomarker, whether we have the right target, but also is this cost-effective, especially at the national level. You have to look at the economics, who's paying for this, and how do you make sure that it's sustainable, because you don't want to run out of funds after treating 10 patients and then not be able to treat the next 100.
So if we're trying to collect a lot of data about people, groups of people, or even specific individuals, what are the costs involved? Could you say a little bit more about what the costs involved are and how we should try to weigh that against the benefits?
So again, the costs, when we look at costs, again, there's no absolute number, right? It's all relative. As you rightly said, it's weighing the cost of doing something versus the benefit, right? And so the question goes back to what is the harm that we are causing by practicing imprecise medicine. So one of the harms is that a study done in Singapore General Hospital showed that 12.5% of admissions were related to adverse drug reactions. If I could identify those individuals without those with those who will develop those adverse drug reactions and make sure that they don't get the adverse drug, I've saved admissions for 12.5% of the patients, right? That's a massive number, right? So it's about taking everything in the context and entirety and weighing both the pros and the cons. So yes, there is a cost of generating the data, but the other thing is there is improvements in technology that are making collection of the data much cheaper by the day. So as we go along, right? Data doesn't need to be just through blood samples. It can be through other non-invasive measures. And so many of us wear smartwatches, which collects data. I'm wearing this thing called Aura Ring, which is a smart ring which collects data as well.
How?
I thought for a second, I thought you were talking about those rings that you get as a kid, those so-called mood rings.
Yeah, that change color if you're feeling angry or sad.
No. So this is a sensor. It's got 3 sensors at the bottom, and it measures my heart rate, my breathing, and variability in my heart rate.
And it's trendy, might I say.
Thank you. I'm not advertising for this one.
Please just drop the name of the brand.
No, so these are called smart rings, and essentially they take away the pain of having to wear a watch. They're really good at night because they can you don't have to wear a watch to sleep. You just wear the ring to sleep.
Yeah.
The battery lasts longer, so they actually do capture good sleep data, and so it's good to track your sleep pattern and also the stress level. So after this interview, I'm going to check on my app what my stress level was. So, surprisingly, even though I think I'm fairly relaxed, it says I'm always in a high stress zone.
Wow, that's interesting. So actually that leads perfectly into my next question, which is how does precision medicine address patient anxiety and unnecessary stress about their health or future health? So for example, I've started swimming And I want to start measuring my, what my cardiac and respiratory rates and all this sort of stuff, blood pressure. I also want to see if I'm improving. But I've been looking at a couple of watches, and it's just like they track so much data, like your sleep and all these sorts of things. I'm like, I sort of don't want to know how bad my health is. And so I haven't got it because I just don't want that kind of anxiety or added stress or added knowing about my life, which means I should be controlling this. Like if I'm aware that it's bad, I should probably fix it. So I'm kind of focusing on ignorance is bliss right now.
Yeah, I guess when I'm at the gym and I'm at the cycling machine, they tell me to put my hands on the sensor so that they can measure my heart rate. And I'm like, I don't want to see my heart rate.
Yeah, I don't need to. I'm doing my best just by being here. I don't need to know that I'm failing as well.
Absolutely. And that actually, in a way, is a bit of precision medicine. It's tailoring what you need in terms of monitoring for your needs. And if that monitoring is going to bring anxiety to you, then maybe it's not the right thing for you, right? So it's understanding that. And that's a nuance that's not easy to capture because it's very individual. And a lot of it is also direct to consumer. It's not through a medical practitioner. So what we do as a healthcare professionals is trying to understand and explain what the different parameters mean, especially when it comes to data collection. When we're collecting data, what would it mean for you in terms of... And so as part of collecting genetics data, what we do is there's this process called genetic counseling, where we actually do, it's both done pre-test as well as post-test. And as part of genetic counseling, we actually inform individuals about what it entails through the test, what are the alternatives, what are the risks, what are the benefits, what are the implications. And because genetics is not just about the individual, we share our genetics with our family members. So what are the implications for your family members if you do find out that you have a genetic condition? And so it's managing that anxiety through a process of giving them information and tailoring that recommendation based on the feedback they give on that.
So walk me through the process of what would happen to me if I wanted to get into precision medicine. In addition to wearing a ring, what kind of tests would I have to go through? Would I want to go through in order to maximize the gains that I get out of precision medicine?
So again, I think the first thing I would do is, not to throw a wet blanket, but the fact is that we're not ready. We're not there yet, right? And that's why precision medicine is still sort of a translational research program that the government is funding to make Singapore a hub in the future, right? So as part of RIE 2020, they've kind of invested in that. We are currently in phase 2. We'll go into phase 3. The challenge is we don't have enough data, right? And when I say we don't have enough data, it's... In the past, it used to be we don't have enough genomic data, right? It started off with not enough genomic data of the Western population because that's where the funding used to come from. So a lot of data got generated. Then it became a problem of underrepresented populations, rest of the world. That is slowly being solved, and Precise is helping to solve some of that by generating genomic data from healthy individuals. So they're looking at sequencing 100,000 individuals. Beyond genomic data, one of the projects that's being led by NTU is called Helios, where they're saying, look, beyond genomic data, we're going to collect different biomarkers. We're going to administer questionnaires. We're going to collect lifestyle data, give you a watch to kind of monitor your thing. Again, trying to understand what could predict and not predict, right? And how does that, and then doing cost-effective studies to say what will or will not work in a healthcare setting at a national scale, right? So if you come to me and say, look, I want to do precision medicine today, I would say, yes, I can, but it'd be very limited, right? And so when I say it's limited to a couple of things. The first thing is that all of us carry variations in our DNA. We have 3 billion base pairs. We have a variant every 1,000 base pairs. So all of us on average have between 3 to 5 million variants. The good thing is 99.9% of them don't cause disease. They are just there because our ancestors had it. And our ancestors probably got it because there was some environmental pressure that led to favorable selection of that variant that got passed down, right? But what we also know is that in about 3% of individuals who are completely healthy at this point of time, they carry variants in genes that are associated with actionable diseases. So things like BRCA1, BRCA2, right, which is a breast and ovarian cancer gene, right? These individuals, they don't have cancer, but they will develop cancer in the future. Identifying those individuals early allows us to screen them. When we screen them, we pick the cancer at an early stage, it's curative. If we don't identify them, we don't screen them, by the time they present, the cancer is advanced, the chances of cure are lower. So we change their healthcare outcomes just by identifying them and putting them through a screening program, right? So that's one example. So 3% of the population have this thing called what we call incidental or secondary findings. And that's what we've been doing at PRISM for the past 6 years, where we've been trying to build workflows to return these incidental findings to participants. The second thing is, again, looking at variables and all that. Again, those are more of nudging behavior rather than actually prescribing anything. But what we showed was that when we compared, the cell, as it grows older, there's at the end of the chromosome, there's this thing called telomeres. So telomeres tell you how old you are, because when you're young, they're long. When you're old, they're shorter, right? And so when we compared individuals by capturing the sleep data using smartwatch and checking their telomeres, what we realized was those individuals who sleep less actually have shorter telomeres for their age.
Don't worry, James takes naps every day.
Yep. So when
You have given me the best news.
Exactly. See, and so that's how we tailor it, right? We say, okay, what's your sleep pattern like? What's your sleep hygiene? Let's optimize that. Then we look at nutrition and say, okay, what is your how do you? And again, the challenge here again is, we don't want to overload you with information, because when we overload information, it's very hard for you to keep track of what needs to be kept track of, right? And so this is where precision medicine comes in again and say, look, out of the 100 recommendations that I would say for any individual, these are the top 3 priorities for you based on your risk factors. So take those, let's modify that, because that reduces your risk in the longer term much more significantly than what's in 97, 98, 99.
That seems fairly manageable. If someone said, across your entire life, there are just 3 things you need to do, I feel like maybe I could give it a go.
If those 3 things are exercise more, eat healthier,
And sleep more. What are the next ones?
Correct.
yeah.
So correct.
Okay. Let's do the other things.
So the way we do it is, again, so it's called incremental change, right? So the first thing you do is you do the top 3. Once the top 3 become habit and you don't even think about those 3, then you go to the next 3, right? So you slowly get to the 100, but you don't start with 100 right from the start. You start with the top 3. And again, the top 3 may be the hardest one. And so you don't say you do 1, 5, and 7, because those are slightly easier to achieve. But you individualize that recommendation based on your risk factors rather than just do it because that's the guidelines.
I have a question. So you say there of the 100, we recommend each person. These are the top 3 that you should focus on. Do you let them know about that the other 97 exist, or do you withhold that for fear of overwhelming the patient?
So that's again a conversation. Again, it's a very individualized. So in some individuals, when we talk to them, you can see the level of anxiety going up as we give more information, and that's when we say, look, this is not a one-time exercise. It's a recurring, and let's stop here, go back, digest this, and come back. We'll see how you're progressing, and then we'll go through the next, right? So I think one of the key challenges here is again, as I mentioned, medicine is an art more than science, is recognizing when there's information overload, and then giving the opportunity to get feedback, and coming back to it at a second or third or fourth encounter, rather than trying to dump everything at the first encounter. And that's something that is very important from a doctor-patient relationship. To me, I think the key tenet of having helping my patients is to build that trust, right? I need them to trust that I'm doing what's best for them. not because I just want to see 20 patients and, I want to do what's best for them. And so building that trust helps, because for me, even though I have an incomplete conversation on day one, when they come back in 3 months, I can carry on that conversation because I built that trust. So I think that's important as well.
I have another question, and you touched on it a little earlier. But the question is, you said something about dealing with implications or secondary findings from genetic information, particularly for genes that belong to families.
Yeah.
So I can imagine, and this is something that's often discussed in bioethics, how or when are you allowed to share information that you discovered through your patient but has serious and actionable consequences for the family? And what happens and what do you do if the patient says, no, you can't share that?
So I'll just focus on genetic findings because, again, from infectious diseases, there are some acts that you may be familiar with, like HIV and all that. So from genetic variants, the current stance is it's still dependent on the individual, at least in the local setting. So if I identify someone as part of the post-test genetic counseling, what we tell them is this is the risk to your family members. And then what we do is we give them a letter saying, please pass this letter to your family members, and they can contact us. And we will do everything else for them, but we can't contact the family members unless the patient consents. And so what we see is that in the pediatric setting, the families are a bit more open to sharing that information. So if I have a child who has a genetic disorder and I identify the parents as carriers, they are more willing to let their siblings know because their siblings may be of childbearing age and they may have children with similar disorder. Yeah. So they want to let which is slightly different experience from the adult setting, where when we tell the adult that, look, you have this and your sibling may have it, they're like, okay. And you go, okay, do you want to give them this letter? Okay. Right?
No.
And so it's
Do you
never
have
a
siblings?
no. Yeah.
So you get it.
Yeah. So in a way, it's harder for adults because they're like, look, yeah. So what I do is I say, okay, Chinese New Year is coming. Besides the ang pao, give this letter as well.
Just wrap it in the present.
Exactly.
It's like, what a nice gift. Here's some money. Also, you might have a disease.
Yeah. No, correct. So, and this is where the challenge is, right? Because you feel that giving that letter means that you're sentencing them to a disease, but actually you're not, right? Because they may not be carrying that variant. The risk is not 100%. The risk is only 50%. So by giving them that letter, and then they come in for testing and they identify that they're not carrying that variant, gives them peace of mind that they won't develop the same disease as their family member, right? Otherwise, they're always living in that fear of, will I develop heart failure because I have this gene that affects my heart when I'm 50 years old or not, right? But if I can tell you that it's not, right? And more importantly, it's about the next generation. So when you say, look, this may be something that they may pass on to their children and it manifests differently, so they may be well at this point of time, but the children may manifest more severely and that's when they say, oh, okay, actually it makes sense, and then they come in for testing. So again, we can't force it, but we encourage them and we bring that up. Again, there have been some case laws, and you're probably familiar with it internationally, where family members have sued the doctor for not informing them about their risk because the index patient had a genetic variant. But so far in Singapore, there hasn't, and there isn't any legal precedence on that at this point in time. Knock on wood, things change, and that's something that we'll have to look at. And again, yeah. So we'll just wait for more guidance on that.
Are there some cases where this sort of data has like some really big public health implications? For example, imaginary case here, a patient walks in, you sequence their genome, and you're like, wait a minute, there might be something here that makes them more resistant to COVID or something like that. Then you might find yourself in a position where you're like, hey, maybe you should tell somebody. get more research done about this.
I thought you were going the zombie way, being like, oh, we've identified some zombie gene.
You might be a zombie.
No. So the other way, right? So I used to run cross country. So the thing is, it's not about being a zombie or an X-Men. All of us have variation in our DNA. All of us have mutations. And that's why we moved away from using the word mutations, because it has a lot of negatives. So we call it variants, and we call it disease-causing variants versus just benign variants, right? So yes, we definitely have patients where we find something very interesting. And so I have a patient who has cured himself of a disease because he developed a mutation that protects him.
Whoa.
Wait. So he developed the mutation whilst he was alive.
Yes.
Was he like actively meditating, like to bring about this mutation?
This is some X-Men stuff.
It is. So I know he's a lovely boy, and I see him once a year, and I joke with him, but he's very special because he has a disease that would cause his bone marrow to fail by the time he becomes 5. When he was born, he did have failure of his bone marrow, so he wasn't producing enough white cells. He was getting infections, and that's supposed to progress and continue to deteriorate until their bone marrow completely stops producing, and they need a bone marrow transplant. This kid developed a mutation that was just downstream of where the genetic defect was. And so even though that gene is the instruction manual is missing, it doesn't matter, because the process keeps going on because he's got a mutation downstream that turns it on.
Evolution in real time.
That might be the coolest thing I've heard this week.
Yeah.
And so his blood counts are completely normal. I still monitor him because I just want to make sure that it doesn't drop.
Yeah, it doesn't mutate back.
Yeah. Or it's always about the balance.
Yeah.
And so far his balance is in the positive side, so his bone marrow is working. But you never know. So that's something. But that's something that happens, right? And so I take it every time he comes. I take a bit of his sample to see what we can, how he's reacting and stuff and like that. So yes, it happens.
Yeah, and are we allowed to, I don't know, send that sample off to more labs, or or try to convince this kid and his parents to agree to off to the labs with you?
Oh no, they're completely on board. So
Yeah.
they are happy to.
They're also amazed.
Yeah, they're amazed, and they're happy to donate the samples.
Yeah.
Because obviously, the implications are not just for him, right? But it has got implications for the rest of the individuals who have bone marrow failure because of this condition.
Yeah.
Because if I can identify those individuals and I can give them whatever he has,
Yeah.
they may not need to go for bone marrow transplant. They just go for this treatment.
I have a kind of like prediction question. I know nobody can make predictions about the future, but when do you think the average person can walk into a hospital and go to a doctor and be like, "Doctor, sequence me," and have a pretty comprehensive, maybe not entirely future predicting, but something like getting your palm read, a sense of the major obstacles and the major kinds of diseases that they need to look out for?
So I would say today we can be done because the technology is there. We know we have a list of genes that we know are clinically actionable. We know variants in those genes that cause disease. So if you came to my clinic today, I could predict for that subset of diseases whether you are at risk or not. The challenge here is, and this is something that is that 97% of individuals will not have that risk. And so it leads to disappointment, right? Because now you're paying X amount of dollars to do the test. And then you say, oh, actually, you're healthy. And you'll be surprised at how people take that because...
And be like, oh, nuts.
I just paid
My
this much.
stupid healthy body.
Correct. So I think that's something that, again, it's part of that conversation that we do in pre-test genetic counseling is to tell them that, look, chances are that you'll come back as healthy. So you manage your expectations so that if they are 97%, then yes, they're okay. And that's something to celebrate rather than be sad about. But if they're the 3%, then we can connect them to the specialists that we have both across the island, right? All 3 clusters have specialists dealing with those conditions, and we can deal with that and go forward from there. So if you ask me, we can practice precision medicine today for the set of conditions called incidental findings. The second thing we can practice, to some extent we are practicing, but it's the Precise is trying to expand on is pharmacogenomics, which we didn't touch on. Pharmacogenomics is how your body reacts. So since 2013, the Health Sciences Authority, which is the FDA equivalent in Singapore, has mandated that all patients who are being prescribed carbamazepine get tested for this genetic locus called HLA-B1502. That's because those who are positive for that at that locus have 100 times higher risk of developing a very severe side effect called Stevens-Johnson's, where they peel off their skin, their mucosa, and they end up in ICU and all that. So those individuals, when they're exposed to carbamazepine and they have the HLA-B1502 allele, they may end up with that side effect. So as a risk, and it's mandated that all patients who are being prescribed carbamazepine, we check the HLA-B1502. At Precise, they're now trying to expand that to other alleles, which don't have such a severe effect, but yes, they do have, and seeing how that can be done. So, yeah.
So, I mean, most of us end up dying of some disease or another at some point in our lives. Yeah, is this 3% as time goes on going to increase to a bigger number, 10%, 50%, 70%, until we can basically discover all the genes or most of the genes that are likely to cause some kind of defect in the future?
Yeah, so absolutely. I mean, I think the idea is, again, medicine is always innovating, or there are innovations in medical technologies to see how we can keep people healthy, right? And the way I look at it is that precision medicine is not just about individual treatment based on individual risk. As you rightly said, all of us will eventually die, right? But what happens is that you in the last 10 years of your life, you develop diseases, and then your last 10 years, you're suffering and you're trying to manage those diseases, right? So yes, you have a longer life, but you may not have the quality of life. What we're trying to do with precision medicine is improve the quality of that longer life, so that you actually have a longer health span where you stay healthy longer before you develop the disease, right? And so the idea is, how do we identify those markers that can predict what the health span should be? So absolutely. So that's something. And there's something that we are doing in terms of the next generation is carrier screening, where we're trying to identify individuals who may be at risk of having children with carrier screening. And this is where I mention all the shout outs to all the partners who helped us, right? So this was based off the first phase of Precise, where they sequenced 10,000 individuals. Our group, together with the rest of this ecosystem, analyzed the data and identified diseases that were commoner in our population that were not covered in currently commercially available panels. And so we built, together with DXD Hub at A-Star, we built a panel that was customized to the Asian genome to test for carrier status of individuals. And if both couples are carriers, then they have a high risk of having a child. So bring them in. So in September, we launched a program called Predict, where we try to identify these individuals and then bring them in for genetic counseling and see how we can help them make that the best decision for their family, right? It's not about mandating it, but it's empowering them with knowledge so that they can then make a decision what suits on their personal belief, their moral belief, their religious belief.
I feel like the next phase of a project, if there is one, should be called Prime, because then you have like Precise, Predict, and then you prime them for the future. You should bring me on.
Absolutely.
I'm always very impressed about how medical researchers come up with catchy acronyms for everything.
And it's very obvious when they fail to do so as well.
No. So that's one thing that you have to do when you're applying for funding in Singapore is to find an acronym that
it's mandated.
Yeah. So my clinic, my NMRC grant is called Sure Find. Mm-hmm. Because I'm sure I'll find something. And then the next phase is going to be Sure Solve, because I found it, now I need to solve it.
And how could they not give you the grant? You said you would do it.
Exactly. And then the final phase will be Sure Treat.
Oh, that's brilliant.
So find, solve, treat.
I love it. I do have one last question. What is the weirdest gene name you know of? Because you're mentioning lots of genes. I'm like, I don't remember any from my degree, but surely you remember some funny ones.
Okay. So not that I can think of right now, but I mean, again, gene names are interesting. And I think the ones that I remember is more from how Excel, which is used to store the data, modifies the gene names, right? So there's a gene called MAR1 and SEPT1. And so what Excel does is it converts them into dates. So everyone who has a mutation MAR1, it's 1st March. Everyone who has mutation SEP1 has 1st September. And so when you're analyzing that data, you actually miss out on those variants because now Excel has filtered them out. They are not gene names anymore, they're dates. So there are, and I'm sure there are gene names that I can't think of right now, but they are. So if you ask me, I would say I have my favorite genes.
Yes, please. Top one favorite gene.
So the
Blue
favorite
denim. My bad. Sorry, I'm just really dying.
What's the best gene?
The best gene is
Bootleg.
the one. No. So the secret is that when we present our work, and if it's not been published, then there's a worry of being scooped. So the way genes are named is MFG1, MFG2, and the acronym stands for my favorite gene 1, my favorite gene 2.
I was thinking of something.
Multifactorial genotype.
Yep. So when you present, this is MFG1 and this is how it functions. So nobody knows what it is.
Yeah.
They just hear the MFG1 and they Google it and they can't find it. But you keep the gene name secret until it gets published. Because it happens that you are at a conference, you're presenting, and then the guy next to you goes, I know what that gene is. And then you're like, oops, call your postdoc, publish the paper today. Because this guy's publishing it tonight. Right, so that's one. Yeah, my favorite is, again, it's the first gene that we discovered. It's called DCC. It's deleted in colorectal carcinoma. It was discovered in 1990, and that was because it was found to be missing in patients who had colorectal carcinoma. So that's why it's called DCC, deleting. 5 years later, folks realized it had nothing to do with colorectal cancer. It had to do with how your neurons cross the midline. So your left and the right hemisphere. And so what DCC does is it's a receptor. So as the neurons are moving, the receptor is there to say, okay, you need to cross, or no, you stay on this side. So DCC modulates that. And that was shown in the fly model, the mouse model in 1995, 96. And then it took us 25 years to actually prove the first human case. So that was that was my first gene discovery project, where we discovered mutation DCC associated with midline crossing defect in individuals, in humans.
So we thought it was to do with the butt, but it was really the brain.
Exactly. Exactly.
I can see the confusion.
Yeah. Some people very easily mix those up.
Yeah. So the fun fact is that DCC, because what happens, your neurons don't cross, so your left hemisphere is one and right is another, and so again, Rain Man, dating back to Dustin Hoffman and Tom Cruise again.
I know this one.
So Rain Man is about this individual who's autistic.
Yeah.
And what he does, he can read cards. And that's because he's got this magnificent memory where he can memorize things. And so it's modeled after an individual, a real-life person, who also had a split brain. We haven't been able to study his DNA, that individual's DNA, but it could be something along that pathway where you've got the left and the right brain acting independently. So what you read from the left eye goes to the left brain and right brain, and then you can read double the...
Imagine studying for an exam where you can read both pages at the same time.
Exactly. So these are things that you pick up. These are things that you see, and these are the extreme ends of the bell curve. You don't have many individuals with that.
That was excellent.
Fascinating.
I think that might also be my favorite gene discovery. So thank you for sharing that. We wanted to thank you so much for coming on the podcast today. This has been a lot of fun.
No, thank you for having me. I mean, I had fun as well.
Thanks for listening to our new podcast. Subscribe online and tune in every first of the month. In the meantime, listen to CBmE and you, and be savvy.